Welcome to Complicating the Narrative, a podcast that takes on the challenging questions in public health by embracing complexity rather than avoiding it. My name is Salma Abdullah. I'm an assistant professor at the newly established School of Public Health at Washington University in St. Louis. I'm a physician by training, and over the past decade, I've had the opportunity to work across clinical medicine, policy, and research, both in my home country, Sudan, and globally. That journey has taught me that the most important questions in health rarely have simple answers. Whether I was treating patients in Khartoum, working on health policy in Geneva, or conducting research in Massachusetts and Missouri, I kept encountering the same reality. The stories we tell ourselves about health are often incomplete, and the contexts we work in are frequently more complicated than they first appear. This podcast exists because I believe those complications matter. In a world with growing polarization, low trust in institutions, including public health institutions, and the rise of AI and global conflicts, we need spaces for evidence-based analysis that can hold multiple ideas in tension, ask uncomfortable questions, and challenge conventional wisdom when necessary. For our pilot episode, I'm thrilled to be joined by Dean Sandro Galea of Washington University School of Public Health. Full disclosure, Sandro has been a mentor to me, and his thinking has profoundly shaped my own approach to public health. He's an epidemiologist, a physician, a prolific scholar, and the author of numerous books including Well and The Contagion Next Time. Sandro is someone who has been thinking about public health of a consequence for a long time. He is also someone who has never shied away from complexity or nuance, even when it's easier to take sides. So I wanted to have him today to talk about his public health career, the moment we're living in, and what it means to build a public health school for the future right now. Sandro, welcome to the podcast.
Thank you, Salma. It's great to be here.
For my first question, I really just wanted to go through your personal journey. What prompted you to join public health and move from clinical medicine? And what kept you going as the field continued to evolve over the past few decades?
Yeah, I for better or for worse, I often think I have a bit of an accidental academic career in public health. I was born and raised in Malta, and I always knew I was going to be a physician. It was perhaps expected of me to become a physician. And when my family immigrated, just before college, it was specifically so I could go to college in Canada and become a doctor. And I did that. I became a doctor, trained in medicine, practiced clinical medicine in some remote and rural parts of the world. And it was really through that practice that I came to realize that there must be something else to keeping people healthy. And I decided I had to go back to school to learn that. And I went back to school to get my master's when I was almost 30, which is pretty old, actually, to sort of get back into a track that then leads to an academic career. And I did that, though, because I wasn't planning on doing an academic career. I did it because I wanted to learn something more than just curative care and to understand a bit better about what makes people healthy. And then when I did my master's, it took. And I decided I need to do a doctorate, and I did a doctorate of public health. And then I've had an academic career since. And I think tying it then to your question of, well, what keeps you going in a career? I guess I've been in my academic career now for about 25 years. And I think what keeps you going is fundamentally mission and purpose. And I decided to go back to school to do a master's because I had an instinct that there is something more to health than simply cure, that there is a way to approach the world that keeps people healthy. And I wanted to be a part of that. And I think what keeps me going is the fact that that is exactly the right mission. That's the right approach. And also it's interesting. I think it's interesting and important. And it's a real privilege to be able to do something that's interesting and important.
That's great. I keep thinking about physicians who move to public health, and I usually think of it as, at least from my career, it was also stemming from seeing patients who we treat. I have a child who was malnourished. We treat at the hospital. They go back in 3 months, and we have to treat them at malnutrition again. I think that sense of, can I do something that actually shapes health at a larger scale, drives a lot of people who move from clinical medicine to public health.
Yeah, and a lot of that echoed my own experience. It's perhaps my most formative experience was when I was working with Somalia and dealing with the cholera outbreak, and I was trained well, and I think as a result, I was a good physician. But what kept haunting me was the idea that I was doing my job and dealing with a cholera outbreak, but it would be much better for the world if there was no cholera outbreak to begin with. And that's a very, very concrete one episode in my life. And I determined to, at the time, really, I just need to learn. I just need to learn what it was about. And since then, I think in my career, I've tried to contribute to creating a world where we do much more of preventing and keeping people healthy. I keep thinking that the role of public health really is to make sure as many people as possible live as long as healthy lives as possible. And that's a pretty, I think, that's a pretty worthwhile aspiration to dedicate one's time to.
That's a perfect segue to my first question, which in it, I really wanted to dive into two concepts that you've written about that have caught my attention. The first one is your argument for consequentialist epidemiology, and the second is your goldfish metaphor. And to be honest, when I read those two pieces, I thought this is exactly the type of scholar I wanted to collaborate with. That was about 10 years ago. And they were part of the reason that drew me to the type of work that you do in the first place. So for our audience, can you just maybe walk us through both of those ideas? I'm curious, how do you think both of those intersect? How do you see them as fundamental, or why do you see them as fundamental for your approach for public health, and how they are shaping your thinking today?
Well, let me start with the goldfish metaphor. I'll work backwards because I think that's foundational to how I think. And the goldfish metaphor, which is sort of emerged over time, borrowed from many people's stories, including David Foster Wallace, is fundamentally you have a goldfish in a bowl and you want it to be healthy. And you can tell the goldfish to exercise, you can feed it organic food. If it's sick, you can get it a good doctor. But unless you change its water, the goldfish is never going to be healthy. And the reason I find that metaphor simple and useful is because one tends to forget about the water. And in a world where we spend all our time providing the goldfish with a doctor, it became clear to me that you want to change the water to keep the goldfish healthy. And as I see it, I was the doctor, trained as a doctor, and then I went back to school to learn about the water. And I think that is what the role of public health is. It is a complement to medicine. And I always want to be clear about that because I never want to be misunderstood as saying that one is a substitute for the other or they're even in competition. But because when the goldfish is sick, you do want a doctor, but ideally you want to keep it as healthy as possible for as long as possible. So public health is about the water. And the water, of course, means having stable housing, having a livable wage, being in a world that's actually free from violence, having clean air, drinkable water. These are all the elements of the metaphorical water. So, number one, that I think animates how I think about in my scholarship and how I think about what an academic institution of public health should do. Number one. Number two, I've articulated this concept of an epidemiology of consequence, really leaning into this notion of consequentialism, which is a philosophical approach that says that you are not bound by priors about what you need to do, but you do what you need to do to achieve your outcome. And I suppose I see public health as a pragmatic discipline. Our goal is to clear the water, to make the fish healthy. And if we're doing that, then our science should point to it. And this is something which I've struggled with because I actually am a big proponent of science and even science for its own sake. But I think what I mean by consequentialism is that we should be doing science that recognizes that the world has needs and science that provides evidence that can have utility. And I, as perhaps with everything else I think about and talk about and write about, I don't mean this in an absolutist sense. I do respect and see the importance of a space for science that is not clearly marked to a place where it's going to improve the world, where we don't know where it's going to lead us. But all I want is for population health scientists to be informed by the world around us and say, how do we do work that creates a better world to create more health?
So thinking about this moment that we're in, and I know you write extensively about this in your Substack, The Healthiest Goldfish, you've described what we're experiencing as the stormy present. Climate change, the rise of AI, political polarization, global conflict, all happening simultaneously. Given that you argue that we should be consequentialist in our approach to public health, I'm curious, what do you think that means for someone who's working in the field right now? And maybe to extend your metaphor just a bit further, when you look at all the water we're swimming in right now, what is the challenge that you worry about the most, especially as a public health professional?
Yeah, I think the moment, if anything, makes the work of public health more important and more interesting because, as you said, you very quickly listed a few of the challenges that the world is facing. And I think all of those are going to matter to people's health. They're all going to matter to the mission, which I articulated earlier, which is how do we make sure that people live as long as possible for healthy as possible. So, number one, I think the work of the scholars who think about that question has become more interesting. Number two, I think that work has become immeasurably more difficult. And I think a lot of the difficulty is traced back to the past 10 years and with the slope of difficulty steepened during COVID. And why do I trace it back to the past 10 years? I think when you look back and at the recent quarter century history, and I'm referring only to quarter century in academic public health because that's the time which I've lived in, and I have no illusion. I'm sure there have been other times when we've entered moments like this, but in the past 25 years, 10 years ago, there was a deepening and a steepening of the intellectual agenda in public health in a particular direction that started excluding others, that became so clearly focused on what it needs to do that lost sight of the fact that a large part of what we need to do is to persuade and to bring people along. That became really acute during COVID when public health was at the forefront of advocating for a very particular approach to dealing with the pandemic that was at odds with how many people felt about it. And I think this is very tricky. It's very tricky because it came from a good place of public health feeling like it had the answers and it wanted the world to embrace them so that the world can be healthier, can be better. But the world wasn't willing to embrace some of them. And I think that has had echoes that continue to this day, putting us in a place where there is deep mistrust of the structures of public health. And I think we are, while we talk about this in public health, I think we're not quite appreciating how deep that runs. You know, someone who I do this blog on a semi-regular basis. I've done books, and I've tried to be careful about what I say publicly, but I do attract people who are trying to be thoughtful, and they send me emails because they see the things I write. And every day, just yesterday, I had a very long email from somebody who's trying to be thoughtful, who kept emphasizing to me that he felt he could not trust public health until public health was upfront and honest about the mistakes it made during COVID. And this is someone who was not, he really is not someone who's throwing flames on social media. Someone who sent me a private email to tell me how he felt like we're not at a point yet where he was willing again to trust public health. And I get these notes on a regular basis, in part because I occupied the space of trying to write and grapple with the challenges of how we think about public health in this moment. And when I see that, I I think that's a real threat because 25 years ago, when I went down into this field, and I went to this field with the aspiration to engage in this project of making sure people can live as long as possible, as healthy as possible, I felt like I could partner with the world around us, and the world around us was going to be a willing partner in that project. Now it feels like we're trying to do this, and the world around us is not so sure that it wants much to do with public health, and that is a real threat.
I guess my challenge here, and I agree with you, I think that we need to engage with different perspectives. I think my challenge as someone who works in academia right now, but who also engage with policy, is that yes, we would like to engage with uncomfortable ideas, with different perspectives. I actually genuinely do believe that that is something that is largely missing in public health right now. But where do we draw the line in practice? As someone who's a dean of a school, but also you're an editor in chief for a journal, Where do we draw the line between honest intellectual exchange and, well, just really bad ideas? How do we have a nuanced conversation about something without just falling into false equivalency that, yes, on one side this, and on the other side this is happening?
I actually have a draft of a Healthiest Goldfish blog that I'll run in sometime next few weeks called The Drawing the Line Problem. I actually literally spent some time thinking about this, and I find writing sort of helps me structure my thoughts, and the piece, you'll see it when it comes out, because I think that's a trick. The line used to be drawn by the experts, and when I say the word experts, you can almost hear me put the experts in quotes, right? It used to be that ideas were published in papers or in journals. There were editors, they were gatekeepers, and when things were published, a line was drawn. This is the truth, and the world accepts it. There was enormous fragmentation of that about 10 years ago when social media became really common, where really anybody could put ideas out there. And that fragmentation went into warp speed in a time of COVID, where everybody had an idea, a perspective, a theory. And I think putting us in a place now where there are no line drawers that are really taken seriously or seen as certainly unquestioned line drawers by the public. Now, part of that, it's not such a bad thing. I actually think it's not such a bad thing to democratize the business of line drawing. But the trick is knowing when to accept that we know something, knowing when something actually is correct and is going to save lives, versus when an idea is just there because it's cranky or because it's trying to stir things up, versus when there is reasonable doubt. And that is a tricky balance. I mean, how do we achieve that? How do we get to that? I mean, I think it's a constant effort at recalibration. I mean, just to be very clear, childhood vaccines for common childhood infectious diseases save millions and millions and millions of lives. And for us to go back on vaccinating children on things like measles is taking us back decades, if not centuries. That is simply wrong. But also, to be clear, the health establishment has leaned into and endorsed using medicines for a number of disorders, particularly things like childhood behavioral disorders, that probably we have been overusing these medications when we haven't been thinking enough about other approaches to help kids with childhood disorders. And I'm putting out two ideas that I currently are contentious in the public space, because the new Secretary of Health and Human Services is, well, I wouldn't say against vaccinating children, conflicted, it seems, about vaccinating children, but also has raised the issue of over-medicalizing children as an important issue. And I think on one of those areas, the issue is over-medicalizing children, he is pushing on the line drawing reasonably. On the other one, he is simply trying to break down well-established scientific consensus, and it's risking people's lives. So I think we need to be able to have the dispassion to say, that might be a good idea that's worth poking at. And that actually is nonsense. We know that that works, and we should lean into it.
So that made me think, I guess, what do you think is the role of social media here? Has social media been helpful in pushing us when we draw those lines? Because in a way, what you're also explaining about how public health was, it was a place where you usually get people who are experts discussing among themselves without really engaging with the larger public. So I'm trying to think, does having increased connectedness, is that more helpful for our discourse moving forward, drawing lines that we usually wouldn't have thought of in the past as expert, or is it hindering our progress in terms of just thinking about the population at large and what can we do as public health professionals?
In general, dispositionally, I'm an enthusiast for technology, and I don't think that any technology at the end of the day is ever going to go back in the box. And there are many positives of social media. I mean, the literature is pretty clear on this. Providing connectivity for people who are remote, providing people communities, particularly people who have marginalized identities. These are all real positives. I mean, there's a positive of entertainment. I mean, social media actually is entertaining. It is so there are many positives of social media. I think the democratization of ideas is very positive. I think it's created an opportunity for people who might have ideas that are outside of the mainstream to get heard, to get a hearing. This is all positive. It has also challenged how we do things. And in the past decade, it has really upended this notion of gatekeeping of ideas. And I think we're at a point where we haven't learned how to use social media properly, aligning it with this drawing the line problem that you're identifying. I tend to think we'll figure it out. That we'll figure it out. That in the next decade, like I think you and I are talking in 2025, 2035, if we're having a conversation by the grace of God, I think it will be a different conversation about social media. So I'm not negative about it, but I also think that we need to be cognizant of the current reality where it's messy. Right now, it's messy. Right now, we don't quite know how to wrap our brain around social media, even as we're learning. I mean, if you look at the political sphere, you see the intersection of social media with, let's call it more traditional mainstream newspapers with gatekeepers. When you look at 7, 8, 9 years ago, the mainstream newspapers had no idea how to deal with social media. They would take all sorts of tweets that were all sorts of nonsense, put them on the front page, which frankly was helping nobody and just inflaming. Now they're much more thoughtful about that, about how to intersect with that. So when I see things like that, I'm like, okay, the world is learning how to use this medium and hopefully learning how to accentuate its positive and mitigate its negatives.
This reminds me of when mass printing first became a phenomenon. I think it was messy for years. Some of the most popular books weren't necessarily what you and I would consider high quality or beneficial for larger society. They were just what was sold really in the market. It took decades for our ability to mass produce books and democratize education to actually start benefiting the broader population in really meaningful ways. I tend to think that we're in a certainly similar messy moment with technology right now, and that we will probably explore more of those themes in future episodes, especially when it comes to AI. But here's where my optimistic side really kicks in. I do think that we might be heading towards a future that we will be able to figure out how to harness the advantages of connectivity and the power of AI while minimizing the downsides of what comes with introducing those type of transformations at a mass scale. I think the question for us really is, how do we try to shape and navigate this transition and what comes next to make sure that we actually move in that direction versus a different direction?
And we have to remember that you and I, Selma, we're both in the academic world, which is we're on the side of the gatekeepers. So as a result, we have a particular bias. You went back to early days of printing, which I think is an apposite example. Of course, in the early days of printing, but the book that was being printed and reproduced was the Bible. The Christian Bible. Some of the earliest battles in the 17th century were about democratizing access to the Bible, and particularly translation of the Bible. So the democratizing act of translating the Bible was a really incendiary issue for decades. Unfortunately, our human lifespan is short, so our view tends to be relatively few years. So you and I are sitting here saying, wow, it's been a messy decade. That's really long time. But in the course of history, it's not very long.
Right. It was religious texts, but it was also a lot of what we would probably consider sensationalist or explicit material today. When you think about it, really, the mix of content that first emerged when we introduced mass printing was fascinating. I guess this brings me to where we're both sitting right now, here in St. Louis, Missouri, because in the middle of what we've been calling this stormy present, you've decided that it's the perfect time to start a new school of public health. And I wanted to dig into what that actually means. I know you've written about concepts like 4x4 or public health plus, but given that we're all facing right now what we just discussed, how do you think this moment is shaping your vision of what a new school of public health needs to do? I'm thinking both about scholarship as a new institution, but also thinking about our educational mission. How do we train the next generation of public health scholars and actually tackle the challenges that we've been discussing today and ensure that populations not only survive but thrive?
Well, in defense of the sanity of those who launched this project and of my own for agreeing to be part of it, we did decide to launch School of Public Health before the president got as stormy as it is now. And I was motivated by this project because I had been in Boston for 10 years, as you know, and before then in New York largely for another 10 years. And I felt I was working in public health, thinking about public health, deeply embedded in public health from a coastal perspective. And I was seeing more and more this unity in the field and the separation of how the coasts were thinking from clearly how the rest of the country was thinking, because there clearly was half the country that was dissatisfied with how the other half was thinking. And when this opportunity presented itself, I thought this would be an interesting moment to be part of a project to build a thoughtful, research-focused school of public health in the middle of the country, literally the middle of the country. St. Louis literally is the population density geographic middle of the country. And so I agreed to be part of this project because I thought it's a place which should have great public health. It should serve the population. Obviously, you want a leading thoughtful school of public health to be global in its engagement and scope, but geography does matter and local geography does matter. Now, of course, when I started here in January, then with the election of Donald Trump and his ascension in late January, it took the context and turbocharged it, because all of a sudden all sorts of changes were happening in the federal health space and the global health space. And I think it put a real spotlight on what does it mean to build a school of public health in this moment, which brings us to your question. I think what it means is build a school of public health that is aware of the directions where the field is headed. And I think where the field is headed is, number one, to try to think differently. This conversation, I mean, your podcast called Complicating the Narrative, is about thinking differently, or at least challenging us to say, how should we be thinking? Number one. Number two is doing things differently. You mentioned in a few sentences ago the introduction of AI, for example. I think there is no question that AI is going to be a transformative technology at this point. I mean, anybody who's using AI knows that it is certainly the most transformative technology that any of us have touched since the introduction of the internet. It really can change how we do things and how we think about things. Number three, thinking about how scholarship that happens in these institutions actually translates to impact. We saw the breakdown, this total breakdown of academic world, scholarship, science, and the needs of the real world during COVID. And how do we bridge that? How do we create those pathways? And number four, how do we do that in partnership? How do we find the partnerships that allow us to do that and to do it well? So I think that's where the field is headed. You alluded to this 4x4 plan that I've articulated. 4 directions where the field is headed: thinking differently, doing things differently, finding clear pathways to impact, and creating the partnerships that make that happen. And then what I've been trying to do is to say, how do we map that onto 4 strategies that we embrace as a school? And the 4 strategies, which in some respects are pretty obvious, they fall out naturally from what one's trying to do in this. Number one is to make sure we have excellent faculty and staff who subscribe to these ideas. Number two is to make sure we have distinctive teaching and to nurture our teachers and students. Number three is to create the partnerships, what I'm calling Public Health Plus, to create the infrastructure for what we're doing. And number four is to commit to local and global impact, which now brings back this idea of a public health of consequence that we started talking about. So I've been trying to conceive of how does one build a school of public health that is responsive to, aware of, informed by, educated by the moment, can contribute to the moment, but also stands the test of time, because fundamentally the promise of institutions like universities is that what you're building in universities will be here for decades and centuries, long after we're long gone.
So if I can push you on that just for a more concrete answer, in terms of what is different about a school of public health. I fully agree with everything that you said about looking into the future of what public health can do. A school of public health, it should answer the moment, but also stand the test of time. But if I can push you on what would be measurably different. You wrote about disenthralling ourselves from old ideas. I actually really like that phrase. If I had to push you and say, what are old ideas in public health that you think we should get rid of or try to at least sideline as we move forward in the future of public health, what would you say?
Well, I think there's a whole catalog of them, but the book I'm finishing now, which will come out next year, is called Why Health, with the subtitle, What We Need to Think About When We Think About Health. And the notion is I'm trying to push us to think about health perhaps differently than the mainstream. And I'll just take a few ideas off the top of my head. Number one, in health, we tend to think that health is the only asset that matters to people. That's not true. Health is not the only asset that matters to people. People actually care about living life well. People want to be healthy so that they can skydive. People are not willing to give up skydiving just because skydiving is risky. This was, to my mind, the canonical mistake made during COVID. I remember early days of COVID when public health was saying the only thing that matters is that we preserve health. And we were willing to sacrifice everything else for that. And people clearly said that that was not what they wanted, because people were not willing, for example, to give up kissing their loved ones as they're dying, and because of the risk of infectious disease transmission. People were not willing to shut down the whole economy because of the risk of infectious disease transmission. So I think one core idea is that health is a means to an end. And that is very difficult for an industry. I'll use the word industry intentionally because public health is an industry like all other industries. It's very difficult for an industry that is focused on creating people's health. So that's one idea. Number two, another idea is that people have similar values about contentious issues. And there are many contentious issues around reproductive rights. These are deeply entwined with people's values. And we in public health cannot assume that just because our values point us to a certain direction, that everybody else is aligned with that direction, which means that we must be involved in the business of understanding that there's a heterogeneity of values and thinking about how to align values with the work that we're trying to do. So these are just examples, I think, of notions that we need to, as I've written, disenthrall ourselves from and wrap our brain around how we engage with these ideas so that we can actually do what we're trying to do, again, which is to create a world where people live long, healthy lives for as much as possible so they can go on and do and live their lives.
So I want to push you a bit on something here. You argue that what we do is both science, but should be also grounded in values. And I do agree that we would be making a mistake if we thought that science on its own should dictate policy or should supersede people's values. But here is where I see that we might have a potential tension. You also advocate for building a big tent, an approach for public health that engages with different values and bring on different stakeholders, and make sure that we have a conversation with all of those who might be concerned with any type of policy that we advocate for. At the same time, our own research that really shows that a lot of the health gaps that we study really stem from power imbalances, particularly economic imbalances. While some people benefit from the current system, others are really being harmed by it. So how do we really reconcile this? If we're trying to create that big tent and engage with stakeholders with different values, don't we risk collaborating with the very people who benefit from maintaining the status quo? How do we ensure that in our efforts to be inclusive and engage different perspectives, that we don't end up advancing the same imbalances that created health gaps in the first place?
I don't think you're talking about one tension. You're talking about many tensions. Let me try to break it down a little bit. Number one, where do you draw the line? This goes back to the drawing the line problem. Where do you as a society draw the line and say that while we're respecting personal autonomy first and foremost, we are not going to allow some things? And sometimes that topic sort of is charged, and in the public conversation, it's almost anathema. You can't say it, but the fact is, we don't allow things all the time. I mean, we don't allow people to scale certain cliffs. We don't allow people to get too close to the railing. These are things we do. We look out for toxic substances, so we don't allow people to do all sorts of things. Now, why do we not allow people to do that? We don't allow people out of a complex understanding of what individual autonomy is about. Individual autonomy, which, by the way, a fancier term for it, which we like better in public health, is the notion of human rights. I mean, human rights are predicated on individual autonomy. But the idea is that everything we do should be to preserve our individual autonomy. But sometimes preserving our individual autonomy means creating the freedom from particular harms, not just the freedom to do everything we want to do. The challenge is, what is that line? Is that line that we do not allow people to ride motorcycles without a helmet? Maybe. Let's say that you and I agree that that's the line. Because why? Well, because the risk of dying if in a motorcycle accident without a helmet is really high. So we are, and I'll use these words judiciously, intentionally, protecting people from themselves. Now, I say those words because those are paternalistic. Because paternalism is inherent in the project of circumscribing individual autonomy. So, but let's say you and I agree that the risks are so high of dying in a motorcycle accident without a helmet. So we draw that line. But we also know if everybody wore a helmet in their car, the injuries in a car accident would also be lower. So why don't we insist on everybody wearing a helmet in a car? Well, we don't insist that because the risks are not so high. But anybody listening to this will know that the space between the risks are very high, therefore we act, and the risks are not so high, therefore we don't act, that's a pretty fuzzy space. Who determines that? Who draws that line? This goes back to the part of the conversation we were having a few minutes ago. Well, that line used to be drawn unquestioningly by gatekeepers, by experts. We're now in a contested space where it's not so clear how much we trust those gatekeepers, not so clear how much we trust those experts. So who gets to draw that line? And what you end up finding, in my assessment, is then people take sides and camps in this debate. There are the people who is what public health revealed itself to be in a time of pandemic, to say, well, then the line should be drawn where we say it should be drawn, and anybody who does not follow that line is somehow not doing things right. And you get the other space, which is, well, then we shouldn't trust anybody telling us anything. There should be no lines drawn, and we should be able to do anything we want to do. I suppose I have been trying very, very hard for the past few years to be assertively in the middle, not on either end, because I do think there are times when you need to draw the line. And I think there are times when we need to have the wisdom not to draw the line. And that's, of course, why I called my last book Within Reason. Now, one of the critiques of that book was, well, who says what's reasonable? And my answer is, well, I don't know. It is a collective consensus that we come to. But I certainly know that we don't get to what's reasonable by simply giving over the power and authority to be reasonable to one side, the side that says wants to draw the line all the time, or another side that never wants to draw the line. Reason has to come from a plurality of conversations, from people with multiple perspectives, having seats at the table, being heard, and us taking incremental steps, making difficult decisions by listening and taking into account the voices of many. Which, of course, when you hear me say that, you might say, well, then social media is a really important tool for that, which is, of course, why I'm simultaneously saying that social media has fragmented our ability to get things done, but also perhaps it's a positive tool if we can learn how to use it properly.
This conversation reminds me of a conversation I had with my mom, who's in Sudan, during the early days of COVID, where I was saying, you need to stay home, like just stay home, don't do anything. And she actually very kindly responded to me saying, this COVID thing that you're talking about seems important. I get your worry, but and Sudan is still going through a civil war right now. But she was telling me, but the bread lines actually now take like an entire afternoon to get the food. So I'm sorry, we're just gonna go stand in the bread lines, regardless of what you're saying. And I think to me that shows the tension of thinking that we can draw the line somewhere that seems reasonable to people. Because my proposition to her was, I'll send you all the money that you need. As long as you stay home, you should be fine. And her reality was just completely different from what I was saying.
Yeah, and I think, look, I think there's a lot of wisdom in that. And one of the things that we learned during the pandemic, and I really do think there were a lot of learnings during the pandemic for anybody who's paying attention, was this notion of contextual facts and the data being applicable to local context. You and I have discussed, for example, our shared frustration with a Western, to use that word for want of a better word, dominated academic intellectual enterprise that prescribed for the world approaches to COVID that were largely inapplicable to, oh, I don't know, one very large continent. And that is all about the gap between understanding the science and its applicability to a local context. And that's really problematic. I mean, that should never happen again.
If I can just end this section with the last question here. Do you think there is any moment where, yes, the very nuanced conversations that we're having are important, but then at a certain point they become a luxury and there is a need for an immediate action?
Yeah,
and
absolutely.
maybe where do you draw that line?
I do think that's the case. And I think, I might use that example as an example, the temporal sequence of dealing with acute disasters. I think when there is a hurricane happening right now outside the window, I actually do think if people's lives are in immediate danger right now, you do need quick, rapid decision making by somebody who's drawing the line, to keep using that term, right now in the immediate moment. But I think we should be conscious of how much what we lose by that, and make sure that we afford that space to a line drawer only under urgent, exigent circumstances. And as soon as those are over, we make sure that we're able to be deliberate and find the reasonable space where most of us can live with, where our values can evolve and shift. I used the term earlier, but I do want to bring it back and answer this question of persuasion. One of the points I've tried to make in my writing and thinking over the past few years is that the role of anybody who is entrusted with, or who wants to be entrusted with, line drawing is persuasion. There is a much easier path, which is one of autocracy and dictating approaches. I think history teaches that it never lasts. Our role is to persuade, shift values, bring people along. And to do that, we need to do that incrementally. One person, one issue, one reasonable position at a time.
Okay, so this podcast is called Complicating the Narrative. And we spoke a lot today, I guess, about drawing the lines and about complications. But maybe even further, when I came to you with this idea, you enthusiastically said the school would support this work. And I want to know, how do we still maybe hold those two positions that are in tension together, where, yes, public health needs to do a better job of communicating, but at the same time, we're supporting a podcast that is asking for more nuance and more complications to a lot more conversations that we have in public health. And I was wondering, do you think there's a tension there? Or do you think we should rely more on just being clearer communicators when it comes to public health, especially in a world of mistrust?
Yeah, I don't think that, I don't think there's tension at all. I don't think clear communication means communicating false certitude. I think clear communication means communicating complexity. And I our School of Public Health has one podcast that we're supporting, this one. And the reason we're doing that is because you are explicitly leaning into asking difficult questions that complicate simple narratives. I think it is a mistake to think that clear communication means here's the answer when we don't have the answer. Sometimes we do. This goes back to drawing the line. I feel like this becomes the theme of this conversation, Salma. Sometimes we do. Your kids should be vaccinated for measles, right? But we need to have the wisdom to know that in most things, that is not so clear. The narrative is complicated. And we can communicate clearly and communicate uncertainty, communicate doubt, communicate what we know and what we don't know. And it is a mistake for us to pretend otherwise, particularly when we have that uncertainty.
So what gives you hope? We talked about complexity, we talked about mistrust, we talked about an uncertain future for public health. What gives you hope right now?
What gives me hope is next. The world is for the living, and the living is propagated generation after generation. And what gives me hope is that you, a generation younger than me, are actually see these complexities and you're grappling with them. I'm not sure that you have answers that are clearer or sharper than ones I have in my mind, but for you, it's intuitive that you actually should be tackling this. Now, I'm not sure everybody, I don't want to cast a broad generational brush, but I do actually think that people who are sort of generation after mine are more questing, more thoughtful, asking deeper questions, less willing to fall into sort of the rut of the intellectual, sort of wagon wheel, and to ask difficult questions. The very fact that you're asking these questions gives me hope. And I don't need you to find answers, because I actually think that answers are difficult to find. But I think asking the questions creates the environment where answers will emerge. And that gives me hope.
And what does success look like for you?
But, I've articulated this notion of radical incrementalism. And what I mean by that is I think it's good to have a radical vision, but to be willing to do the hard incremental work of getting there. Radical vision is all of us, you, me, anybody who's listening to this, live as long as possible, as healthy as possible. That's the radical vision. We're not going to get there in my lifetime. We're not going to get there in your lifetime. But I'm committed to the incremental work of getting there. Part of that work is having conversations like this, which are intended to shift how people think and intended to shift values. Success, I'll take incremental success.
I don't know about you, but I think I would like to believe that I'll live forever. So every time you say like your lifetime, your generation, it just makes me feel older, but that's fine. But my approach to this,
at my age, I'm coming closer to grips with my mortality.
No, I agree with you. I think it is getting into success, or getting to success in public health, also requires understanding that success will probably take a much, much longer time than we think. Like, I think that's my approach to public health, which is, it's been frustrating coming from clinical medicine, because I thought I would like to help a larger segment of the population. And then you get to public health and you realize to actually achieve that dream, that takes a long time for it to be something that is grounded in systems and something that did not change overnight. That takes a lot of time, and you'll probably not be there to actually witness the success that you were looking for. Okay, well, thank you so much, Sandro. I think we just have like one last question that I would like to ask all of my interviewees, which is, this is a show that is called Complicating the Narrative. And we picked that name because we think that simple stories often miss important nuances. What is a narrative that you think needs complicating? Or what is a question that still keeps you up at night?
Oh, it's an excellent question. I think I'll lean into something that's been a thread through our conversation, which is the question of the limits on individual autonomy. I think that is a question that gets at the very heart of everything I've been studying and thinking about for 25 years. Because when you talk about the water and changing the water, to come back to the goldfish analogy, it is ultimately you are limiting the goldfish's ability to be healthy, less healthy by changing the water, how frequently you change it. It is a limit on individual autonomy. And how much we are willing to limit and how much we're willing to allow, I think is at the heart of everything we do when we think about population health. And that, I think, is a really interesting question. I think it's really interesting ethically, it's really interesting philosophically, and I think it raises really interesting policy, practical questions and should inform the science we do.
Thank you, Sandro Galea.
Thank you so much. It's great to have the conversation.
This podcast was edited by Zach Leonaris and Catalina Melendez Contreras. It is supported by the School of Public Health and Frick Initiative at Washington University in St. Louis. You can access this and other episodes wherever you get your podcast, or you can watch it on video on YouTube. Thank you for watching.